Welcome to PRISM Rounds, the audio journal club for busy ICU, ED, and pulmonary/critical care teams. Each episode breaks down one study at a time: clinical question, design, key results, limitations, and bedside relevance. So new evidence is easier to digest and apply in real-world practice. I started these episodes for my own learning and share them in case they are useful to other clinicians and learners. This podcast is for educational purposes only and is not medical advice. Clinical decisions should always be made in the context of the individual patient and treating team. Please like, subscribe, and share this episode with a colleague who may find it useful. In the Victory trial, high-dose IV vitamin C in severe burn injury did not improve organ dysfunction or discharge outcomes and raised a concerning mortality signal, reinforcing caution against routine use in critically ill patients outside clinical trials.
Imagine standing in front of a raging house fire. Right. You pull the hose, you start spraying, and suddenly the water you're spraying spontaneously turns into gasoline.
Oh, wow. Yeah, that's a terrifying thought.
Exactly. I mean, the harder you try to extinguish the flames, the faster the whole structure just burns down. And on a cellular level, that is effectively what the critical care world discovered they were doing.
When they tried to, cure severe burn shock with massive pharmacologic doses of vitamin C.
Right. So welcome to this deep dive into a stack of, frankly, fascinating and highly clinical sources that you shared with us. We're going to be focusing heavily on the Victory trial, which was published in JAMA in 2026.
And this is huge. I mean, if you are managing patients in a burn unit or a medical ICU or even the emergency department, this trial fundamentally disrupts a therapy that a lot of people consider to be a completely benign biological silver bullet.
Yeah, it really does. And our mission today is to basically dissect that exact paradox, because we need to figure out why this elegant biological story of ascorbic acid, its celebrated ability to fight oxidative stress and preserve the endothelial glycolytics, why that completely fractured when it was put to a real test.
When it was subjected to actual patient-centered outcomes in severe burns. Because the clinical shift here, it really can't be overstated. We are looking at a rigorously designed phase 3 trial that didn't just fail to show a benefit.
Right. It didn't just, do nothing.
No, it actively crossed the statistical threshold for harm. We're going to unpack how a foundational micronutrient, literally something essential for human survival, was somehow transformed into a toxic intervention.
Just by altering the dose in the clinical context, it's wild. And beyond just the burn unit, we really need to analyze what this means for the broader medical ICU, especially for patients battling septic shock or ARDS or, multi-organ failure.
Which means we kind of have to separate our deep-seated reliance on mechanistic plausibility, how things work on paper, from the often brutal reality of empirical evidence.
Yeah, the real world. Okay, let's unpack this. Because for over 2 decades, high-dose intravenous vitamin C, it was sort of the ultimate biological duct tape in critical care, right?
That's a great way to put it. It was viewed as this cheap, globally available thing that could theoretically interrupt the deadly cascade of shock.
So let's pull back the curtain on that pathophysiology for a second.
Yeah.
Because to understand why the Victory trial was designed and ultimately why it failed, you really have to look closely at what happens systemically with a severe burn.
Right. We are talking about deep second-degree or third-degree burns covering 20% or more of the total body surface area.
The TBSA, yeah. And at that threshold, this ceases to be a local skin injury.
Exactly. It becomes a catastrophic systemic inflammatory event. The moment you get that magnitude of thermal injury, all that necrotic tissue triggers a massive release of DAMPs, damage-associated molecular patterns, right into the systemic circulation.
And that just sets off the alarms everywhere.
It initiates a profound systemic inflammatory response syndrome. The immediate consequence is this staggering release of oxygen-free radicals. We're talking superoxide anions, hydroxyl radicals.
Alongside just a massive surge of pro-inflammatory cytokines like interleukin-6 and TNF-alpha.
Yes. And the primary victim of that cytokine and free radical storm is the vascular endothelium.
The lining of the blood vessels.
Right.
And we are not just talking about the gap junctions pulling apart, right?
Yeah.
We are looking at the rapid, widespread degradation of the endothelial glycolytics.
That protective gel-like layer.
Yeah, all those glycoproteins and syndicants lining the inside of every single blood vessel. When those free radicals basically shear the glycolytics right off the endothelium, the structural integrity of the capillary bed is just obliterated.
Which results in profound capillary leak syndrome. All that intravascular fluid plus critical plasma proteins like albumin, they just third space right into the interstitium.
They just leak right out of the pipes.
Exactly. This drives massive tissue edema while simultaneously plummeting your intravascular volume. The patient rapidly goes into distributive and hypovolemic shock.
And if you don't replace that volume aggressively, you lose perfusion to the gut, the kidneys, the brain, the heart.
And you inevitably end up in multi-organ failure.
Which is why the cornerstone of early burn management is massive fluid resuscitation. I mean, clinicians are at the bedside calculating volumes using the Parkland or modified Brook formulas, and they're often pouring tens of liters of crystalloid into these patients in the first 24 hours.
Just to maintain a viable mean arterial pressure.
But that life-saving fluid, it's a double-edged sword, isn't it?
It absolutely is, because loading a patient with massive volumes of crystalloid exacerbates that tissue edema we just talked about. It drives up intra-abdominal pressure,
Which can precipitate abdominal compartment syndrome.
right. It floods the alveolar spaces, causing profound respiratory failure. And the peripheral edema can get so bad that it physically compresses the arterial supply to the arms and legs.
Which means emergent escharotomies or fasciotomies. You literally have to cut the skin to relieve the pressure.
Yes. So the holy grail of burn resuscitation has always been finding some kind of adjunct therapy, something that could, chemically seal the endothelium, stop the capillary leak, and fundamentally reduce the total volume of crystalloid you need to give.
And this is exactly where ascorbic acid, vitamin C, entered the intensive care spotlight. Because if the human vascular system after a burn is like a network of violently leaking pipes, and vitamin C is the biological sealant that patches the holes, why wouldn't we want to use as much of it as possible?
Well, the biochemical rationale is admittedly brilliant on paper. Vitamin C is a highly potent electron donor, so in a system that is just completely overwhelmed by oxidative stress, introducing a massive exogenous load of an antioxidant should theoretically scavenge those free radicals.
Just neutralize them on contact.
Right, neutralize them and halt the destruction of the glycocalyx. But the biochemical appeal actually extends even further than direct scavenging.
Wait, really? What else does it do?
It's an essential enzymatic cofactor for dopamine beta hydroxylase.
Okay, and the body needs that to synthesize endogenous catecholamines, right? Like norepinephrine and epinephrine.
Exactly. So by supporting endogenous vasopressor synthesis, it theoretically helps the blood vessels maintain their tone and responsiveness during shock. Plus, it acts as a cofactor for another enzyme crucial for vasopressin synthesis.
Wow. And we definitely can't forget its role in collagen synthesis. I mean, it's a required cofactor for prolyl hydroxylase and lysyl hydroxylase, which basically means it stabilizes the collagen triple helix.
Which is critical for wound healing. For a burn patient whose survival ultimately depends on their skin healing and successful grafting, giving a drug that directly fuels collagen production seems like, well, an undeniable clinical mandate.
Yeah, it makes perfect sense in a textbook.
Yeah.
And the enthusiasm wasn't just theoretical, right? I mean, it was heavily reinforced by some early clinical data.
Yes, the most influential one was probably the trial published by Tanaka and colleagues back in the year 2000.
I remember that one.
They gave an aggressive, continuous infusion of high-dose intravenous vitamin C. We're talking 66 milligrams per kilogram per hour for 24 hours to severely burned patients.
And the outcomes they reported from that Tanaka study, they were exactly what the critical care community was desperate to see.
They documented a drastic reduction in the volume of resuscitation fluid required. They saw significant reductions in burn tissue edema.
And even a decrease in the days patients spent on mechanical ventilation, right?
Exactly. It painted this beautiful picture of a therapy that effectively halted capillary leak.
But, and this is a big but, that was based on a pretty small study.
A single-center study with only 37 total patients.
37. But despite that, the intervention gained massive traction. The fluid-sparing effect just seemed so profound that over the next 2 decades, retrospective analyses and smaller observational cohorts largely echoed the same sentiment.
The critical care community really leaned heavily into this pharmaconutrition strategy, to the point where major international burn and nutrition guidelines actively suggested routine high-dose vitamin C supplementation for major thermal injuries.
I mean, that historical context is so vital for you to understand because it illustrates how deeply entrenched this therapy became based on a really small, albeit physiologically compelling, data set.
Because if a little bit of biological sealant patches the microscopic holes, then a massive continuous infusion should armor the entire vascular tree.
Right. But the human body, in profound dysregulated shock, is not a predictable closed-loop chemistry set. It is a chaotic, highly complex biological system.
And that brings us directly to why the Victory trial was designed. The investigators recognized the disparity between a 37-patient trial from the year 2000 and modern standards of evidence-based critical care.
They wanted to test the duct tape.
Exactly. The overarching objective was to subject this highly adopted, biologically elegant theory to the most rigorous, unforgiving scientific methodology available.
An international, randomized, double-blind, placebo-controlled Phase 3 trial.
Yes. Let's tear into the architecture of this trial, starting with the logistics. Because this was a sprawling, multinational effort. It encompassed 24 specialized burn centers across North, Central, and South America, as well as sites in Europe and Asia.
Which is so important, right? Capturing that kind of global patient diversity is critical to ensure the results aren't just an artifact of one specific hospital's local protocols.
Absolutely. And the inclusion criteria were carefully calibrated to isolate the specific phenotype of profound systemic burn shock. They only enrolled adult patients who had deep second-degree or third-degree burns involving at least 20% of their total body surface area.
Because, like we mentioned earlier, that 20% mark isn't arbitrary. That's the widely accepted physiological inflection point, where a burn goes from being a localized issue to triggering that massive systemic capillary leak.
Right. And furthermore, the injuries had to be severe enough to require definitive surgical skin grafting.
So they were sick. And looking at the baseline data, the average patient enrolled ended up being around 49 years old, heavily male at 79%, which tracks with standard burn epidemiology. But the most striking data point to me is the severity of the injuries.
The burn size.
Yeah, the trial average was a burn size of roughly 37% of the total body surface area. I mean, a 37% TBSA burn is a catastrophic, highly lethal injury. It immediately thrusts the patient into a multi-organ failure trajectory.
It really does. And to maintain the integrity of the data, their exclusion criteria were equally strict. Patients had to be randomized and receive the intervention within 24 hours of the initial injury.
What's the rationale there? Why the 24-hour cutoff?
Well, the most violent phase of capillary leak, and therefore your highest requirement for fluid resuscitation, happens within that initial 24-hour window. So if you initiate the sealant after the leak has already peaked, you kind of miss the primary therapeutic target.
That makes perfect sense. They also excluded patients with a known deficiency in glucose-6-phosphate dehydrogenase, or G6PD, which is a fascinating physiological caveat.
It really is.
Because G6PD is an enzyme in the pentose phosphate pathway that red blood cells rely on to maintain their own supply of glutathione. And glutathione protects them from oxidative damage.
Right, and if you give massive pharmacological doses of vitamin C to a G6PD deficient patient, the ascorbic acid can actually overwhelm their limited antioxidant defenses,
Triggering massive red blood cell lysis and acute hemolytic anemia. Not something you want to do to a burn patient.
Definitely not. They similarly excluded patients with a history of recent kidney stones. And we'll get into exactly why that matters when we discuss the renal metabolic pathways of ascorbic acid shortly.
And importantly, they excluded patients receiving hydroxycobalamin, which is a common antidote for suspected cyanide poisoning secondary to smoke inhalation.
Because it chemically interferes with the assay they use to measure serum vitamin C levels?
Okay, so with that population defined, let's analyze the intervention itself. Because the protocol mandated a dose of 50 milligrams per kilogram of body weight given intravenously every 6 hours for a total duration of 96 hours.
And what's fascinating here is the magnitude of that dose. It is the defining characteristic of this entire clinical question. We have to clearly delineate between standard physiologic repletion and true pharmaconutrition.
Break that down for us.
Sure. If a patient is critically ill and experiencing a depletion of their endogenous vitamin C stores, which frequently occurs in the ICU, physiologic repletion involves administering, say, 1 to 200 milligrams a day just to restore normal enzymatic function.
Just putting back what's missing.
Right. But 50 milligrams per kilogram every 6 hours is an entirely different pharmacological universe.
Yeah, let's do the math on that. For an 80-kilogram adult, 50 times 80 is 4,000 milligrams per dose. And if they are getting that every 6 hours over a 24-hour period, you are infusing 16,000 milligrams, 16 grams of intravenous vitamin C.
Which is hundreds of times the normal physiological requirement. The intent is no longer to simply replace a missing nutrient. The intent is to use this molecule as a heavy-duty, target-saturating drug to forcefully alter the systemic inflammatory cascade.
It's a massive sledgehammer.
Yeah.
And the control arm, to maintain the double-blind integrity, they just received a volume-matched placebo infusion on that exact same 96-hour schedule.
Exactly. Now, one of the most pragmatic aspects of the trial design was how they handled the background fluid resuscitation.
I thought this was super smart. Rather than forcing every global burn center to adhere to some rigid artificial fluid protocol, they let the clinical teams use their local standard of care.
Right, most centers utilized that modified Burke formula we talked about, titrated to urinary output. Permitting local titration to physiologic endpoints like urine output and mean arterial pressure is what makes this a highly pragmatic trial.
Because if the vitamin C truly possesses a fluid-sparing effect, that effect should just naturally reveal itself at the bedside. The nurses and doctors would find themselves needing to titrate down their fluid rates to maintain the exact same physiological targets.
Precisely, which brings us to the statistical heart of the trial, the endpoints. I mean, put yourself in the shoes of a trial designer. How do you measure success or failure in population this critically ill?
They chose a primary composite endpoint, right? Death by day 28, or the presence of persistent organ dysfunction at day 28.
Yes, and the utilization of that specific composite endpoint is a really sophisticated statistical choice. It addresses a major pitfall in critical care research known as competing risks, or survival bias.
Because if a trial only looks at mortality, it might deem a drug successful just because the patient is technically alive at day 28.
Right. But if that patient is alive solely because they are permanently tethered to a dialysis machine, paralyzed on a mechanical ventilator, and requiring maximum vasopressor support just to maintain a pulse.
I mean, categorizing that outcome as a therapeutic win is clinically disingenuous. Modern intensive care can sustain biological life long past the point of meaningful recovery.
Exactly the issue. By grouping mortality together with persistent organ dysfunction, which they defined rigorously as ongoing mechanical ventilation, the requirement for kidney replacement therapy, or continuous vasopressor and inotrope support, they ensured they were measuring an outcome that actually matters to the patient's long-term trajectory.
It's about quality of survival, not just avoiding death. And they supported that with a main secondary outcome looking at the time to discharge alive from the hospital within 90 days. Again, a metric deeply tied to actual recovery.
So the architecture is basically flawless, a massive global phase 3 trial powered for over 600 patients, primed to definitively validate the standard of care.
Except the trial never reached that 600 patient target.
No. It was abruptly terminated after only 238 patients had been randomized. 120 got the vitamin C and 118 got the placebo.
The Independent Data and Safety Monitoring Board, the DSMB, they basically pulled the emergency brake at the very first interim analysis.
Right. In major clinical trials, the DSMB uses these predefined statistical boundaries to monitor the unblinded data in real time. They are looking for either overwhelming efficacy, where it would be unethical to continue giving a placebo, or they are looking for severe safety signals.
And in the case of the Victory trial, they didn't halt it for efficacy.
No. They halted it because the data aggressively crossed the predefined statistical thresholds for futility and harm.
Meaning the intervention was not only failing to help, it was statistically injuring the patients receiving it. Here's where it gets really interesting. Let's dissect the hard numerical data because the signal here is just staggering.
It really is. For the primary composite outcome, death or persistent organ dysfunction at day 28, the event rate was 40.8% in the high-dose vitamin C group.
And in the placebo group?
It was only 29.7%.
Wow. So that generates an adjusted risk ratio of 1.28 with a 95% confidence interval stretching from 0.99 to 1.65.
And while the lower bound of that confidence interval flirts with the line of no effect, the clinical reality of the absolute numbers cannot be ignored. We are looking at an absolute risk increase of approximately 11%.
Let's translate that 11% into bedside terms for you. It means the number needed to harm the NNH is roughly 9.
Right. For every 9 severe burn patients you proactively treat with this specific 16 gram per day vitamin C protocol, you mathematically cause 1 additional patient to either die or suffer permanent organ failure who otherwise would have survived intact on placebo.
That is deeply unsettling. And the data becomes even more concerning when you isolate just the mortality component of that endpoint. The 28-day mortality rate was 15% in the vitamin C cohort, compared to a mere 7.6% in the placebo cohort.
That yields an adjusted risk ratio for mortality of 1.96.
It almost doubled it. The intervention essentially doubled the risk of death in the first month. The absolute risk increase for 28-day mortality is 7.4%, translating to a number needed to harm a 14.
Treating 14 patients with the biological duct tape directly resulted in 1 excess death. And the hospital mortality data followed the exact same trajectory, landing at 23.3% for the intervention group versus 16.1% for placebo.
And what about that secondary outcome, time to discharge alive?
Absolutely no improvement.
Okay, but what about the fluid-sparing effect? The whole foundational premise of the therapy from the year 2000 Tanaka study. Did the 16 grams of vitamin C at least stop the capillary leak and reduce the volume of resuscitation fluid?
The trial data thoroughly dismantled that premise, too. The investigators closely tracked the median fluid volumes administered during the ICU stay. Surprisingly, the vitamin C cohort actually required a slightly higher median volume of fluid.
Wait, they needed more fluid?
Yeah. 5,908 milliliters in the vitamin C group compared to 5,096 milliliters in the placebo group.
That completely contradicts the historical premise. The expected physiological benefit just evaporated under the scrutiny of modern, protocolized resuscitation, leaving behind nothing but a devastating harm signal.
Which confronts the clinician with a deeply unsettling paradox. I mean, how does ascorbic acid, a ubiquitous, over-the-counter, water-soluble vitamin, transform into a critical care toxin capable of doubling the mortality rate in burn shock?
That is the million-dollar question. And while the VICTORY trial was designed to measure clinical outcomes rather than explicitly define cellular mechanisms of toxicity, the physiological environment of a severe burn provides several highly credible biological explanations for this paradox of harm.
Right, because when you push massive pharmacological doses of a compound into a severely dysregulated metabolic system, you invariably activate alternative, often destructive biochemical pathways.
So let's explore the first major hazard, oxalate nephropathy.
Okay, let's trace this. The metabolic fate of ascorbic acid is not simply to circulate indefinitely. It has to be metabolized and cleared. Ascorbic acid is oxidized into dehydroascorbic acid, which is then rapidly hydrolyzed into dictogolonic acid.
And the terminal breakdown product of that chain is oxalate.
Exactly. Now, in a healthy euvolemic individual taking a dietary supplement, the renal transporters efficiently clear that oxalate into the urine. No problem.
But a burn patient isn't healthy or euvolemic. The pathophysiology of a burn alters every single variable in that equation. The patient is profoundly hypovolemic, meaning renal plasma flow is drastically reduced.
And the kidneys are simultaneously trying to conserve volume, resulting in the production of highly concentrated urine with a very low pH.
So you have this hypovolemic, acidic renal environment, and you suddenly flood the proximal tubules with massive supraphysiologic quantities of oxalate derived from the 16 grams of intravenous vitamin C.
And in that specific hyperosmolar acidic milieu, the oxalate rapidly binds with calcium. It forms calcium oxalate crystals. This results in supersaturation and physical precipitation right within the delicate renal tubules.
The crystals physically obstruct tubular flow and trigger localized inflammatory necrosis, which manifests clinically as severe acute kidney injury.
And the VICTORY trial data strongly corroborates this mechanistic theory. If you look at the requirement for kidney replacement therapy, meaning the acute kidney injury was severe enough to mandate dialysis, it was initiated in 10.8% of the patients in the vitamin C arm.
Versus what in the placebo arm?
Only 5.9%.
Wow. The intervention nearly doubled the rate of catastrophic renal failure.
It did, but the physical destruction of the renal tubules by oxalate crystals is just one hazard. It's likely compounded by a second, more insidious cellular mechanism, the paradoxical pro-oxidant effect.
And this directly challenges the core rationale for using the drug in the first place. We established that vitamin C is an electron donor, acting as a potent antioxidant to quench free radicals. How on earth does an antioxidant suddenly start generating oxidative stress?
It comes down to the complex transition metal chemistry happening in the blood of a burn patient. In a major burn, you have extensive tissue necrosis and red blood cell hemolysis. This releases massive amounts of free, unbound iron and copper into the systemic circulation.
Okay, so you have all this free iron.
Right. And when you introduce massive concentrations of ascorbic acid into an environment saturated with free iron, you fuel a catastrophic catalytic process known as the Fenton reaction.
Let's trace the chemistry of that Fenton reaction because it's wild. The ascorbic acid actually donates an electron to reduce the circulating ferric iron, the Phthalate+, down to ferrous iron,
Yeah.
Fe+.
And that ferrous iron then violently reacts with endogenous hydrogen peroxide, generating massive quantities of highly destructive hydroxyl radicals.
So instead of neutralizing the oxidative fire, the megadose of vitamin C acts as a continuous electron shuttle, rapidly cycling the free iron and actively generating one of the most tissue-destructive free radicals known to biology.
Exactly. In the dysregulated redox environment of a severe burn, the intended antioxidant paradoxically functions as a potent pro-oxidant. It accelerates the destruction of the cellular membranes and the endothelial glycocalyx it was supposed to protect.
Think of the body's redox state, in this case, like a heavily flooded internal combustion engine. The free iron is the excess fuel pooling in the cylinders. Now, normally, vitamin C acts as a precision spark plug, perfectly timed to burn fuel efficiently.
I like that analogy.
But when you drop 16 grams of vitamin C into that flooded engine, you aren't fixing the timing. You are continuously sparking an uncontrollable engine fire that literally melts the block. We thought we were tossing a pillow onto the seesaw to balance it out, but instead we dropped a bowling ball that broke the board entirely.
That mechanical analogy perfectly illustrates why context and dose are inseparable in pharmacology. And that leads to the third major biological hazard, which is entirely logistical but highly lethal: the formulation and acid base load.
Right, because intravenous vitamin C doesn't just materialize out of thin air. It is manufactured as a highly concentrated hyperosmolar stock solution, usually containing 500 milligrams per milliliter of ascorbic acid.
And ascorbic acid is, chemically, a formidable acid. Delivering 4,000 milligrams every 6 hours requires the pharmacy to dilute that highly concentrated hyperosmolar acid into a carrier fluid.
So you are forcefully infusing a massive unbuffered acid load directly into the central circulation of a patient who is probably already battling profound lactic acidosis from their shock state.
Exactly. A burn patient with hypoperfused kidneys and failing lungs has virtually zero biological buffering capacity left. Their bicarbonate is likely already depleted.
Pumping that volume of raw titratable acidity into their vasculature can precipitate severe acidemia, which actively depresses myocardial contractility and renders the peripheral vasculature completely unresponsive to endogenous and exogenous catecholamines.
You basically induce a state of refractory vasoplegia, which, ironically, might explain why the clinicians in the Victory trial actually had to administer more fluid to the vitamin C group.
Oh, because the acid load may have worsened the shock state, forcing the bedside teams to aggressively up-titrate their crystalloid infusions just to chase a falling blood pressure.
Precisely. However, recognizing all three of these hazards, the oxalate crystallization, the Fenton-driven pro-oxidant cascade, and the iatrogenic acidemia, we do have to maintain rigorous analytical discipline here.
Right. We shouldn't overstate the exact mechanism. The Victory trial was designed to prove clinical harm, which it did definitively. It was not designed to isolate which specific biological failure point triggered the mortality in any given patient.
That nuance is crucial. The reality is likely a heterogeneous combination of all three hazards, varying based on the individual patient's renal function, hemolysis rate, and baseline acid-base status. But for the intensive care physician at the bedside, the precise cellular mechanism of death is secondary to the undeniable empirical outcome.
The intervention at this dose in this population is lethal. Which, forces a massive pivot in our analysis. Because the clinicians listening to this who staff the medical ICU or the emergency department are likely thinking, well, this is a fascinating dissection of burn pathophysiology, but I manage septic shock. I manage ARDS. I don't treat 37% TBSA thermal injuries. Does this burn data actually dictate my practice?
And the clinical answer to that is profoundly affirmative. To contextualize the relevance of the medical ICU, if we connect this to the bigger picture, we have to look beyond burns and connect the Victory trial to a preceding landmark study, the Lovett trial. Love it. Standing for lessening organ dysfunction with vitamin C, published a few years prior to Victory. And this phase 3 trial investigated a completely different critical illness phenotype, right? Patients admitted to the ICU with profound septic shock requiring vasopressors.
Yes, and the baseline pathophysiology of septic shock diverges radically from burn shock. A burn is a massive, sterile thermal injury resulting in immediate volume loss and damp-mediated inflammation. Sepsis is an overwhelming infectious process where pathogen-associated molecular patterns, or PAMPs, trigger profound systemic vasodilation and complex immune dysregulation.
But despite those divergent physiological starting points, the Levy investigators tested an identical pharmacological intervention. They utilized the exact same dose, 50 milligrams per kilogram every 6 hours, for 96 hours.
And despite the different disease processes, the clinical outcome was completely identical. The Levy trial demonstrated that high-dose intravenous vitamin C failed to offer any survival or organ-sparing benefit in septic shock. And furthermore, just like in Victory, it generated a clear safety signal, actively increasing the risk of death and persistent organ dysfunction in the sepsis cohort.
We're looking at a terrifying convergence of harm signals here.
Yeah.
2 massive, rigorously conducted international phase 3 trials. 2 entirely distinct populations of critically ill patients. The exact same supraphysiologic dosing protocol. And in both instances, the drug actively hurt the patients it was theorized to save.
I mean, this convergence effectively dismantles the biological arguments that have been heavily promoted for years to justify routine high-dose vitamin C in the medical ICU.
It really does. The theories that it fixes capillary leak, quenches oxidative stress, and bolsters catecholamine synthesis in sepsis and ARDS have now been empirically falsified by patient-centered outcome data.
The burden of proof in the critical care community has definitively shifted. For years, the prevailing attitude was, oh, it's just a water-soluble vitamin, we might as well give it, because at worst, they'll just pee it out and it can't possibly hurt.
And that heuristic is now completely obsolete. We possess definitive, reproducible evidence that it can and does cause severe harm. Clinicians must become deeply uncomfortable with the routine use of high-dose intravenous vitamin C outside of a highly regulated formal clinical trial setting, regardless of whether the patient has a burn, sepsis, or multi-organ failure.
Okay, I want to carve out a very specific, absolute clarification right here, because medical practice has a dangerous tendency to swing violently from one extreme to the other. The takeaway is absolutely not vitamin C is bad.
No. A vital distinction. Ascorbic acid remains an absolute biological necessity. Critically ill patients, owing to their hypermetabolic state and high levels of oxidative stress, frequently consume their endogenous stores. They develop profound scurvy-like deficiencies during prolonged ICU stays.
So standard physiologic repletion remains a non-negotiable standard of care. If you have a patient with a documented or highly suspected deficiency, administering normal nutritional doses, perhaps 1 to 200 milligrams a day, or even slightly higher, if utilizing standard enteral or parenteral nutrition formulations, is essential to restore normal enzymatic function.
Exactly. The danger, the pathology, emerges exclusively when we cross the line from physiologic repletion into aggressive ICU pharmacotherapy. Administering 200 milligrams to restore baseline biological function is sound medicine.
Pumping 16,000 milligrams into a central line to try and chemically bludgeon a shock state into submission is where the oxalate crystallization and prooxidant cascades begin. The dose, combined with the context of hypovolemic shock, literally makes the poison.
It does. And when you evaluate the Victory trial alongside the historical context provided in the source material, it forces a profound sense of humility regarding the history of critical care medicine. The ICU literature is essentially a graveyard of biologically flawless therapies that generated intense early enthusiasm, only to fail catastrophically when subjected to rigorous human trials.
The sources specifically highlight this saga of activated protein C as the prime historical analog to this vitamin C phenomenon.
Oh, yes. Introduced in the early 2000s under the brand name Sigris, activated protein C was championed as the ultimate cure for severe sepsis.
And the biological rationale for activated protein C was genuinely beautiful. I mean, sepsis triggers a lethal triad of inflammation, it spread microvascular thrombosis, and impaired fibrinolysis. Activated protein C is an endogenous molecule that simultaneously exerts potent anti-inflammatory, anticoagulant, and profibrinolytic effects.
It seemed perfectly engineered to dismantle the pathophysiology of sepsis. And following the initial prowess trial, which showed a seemingly massive mortality benefit, the critical care community rapidly adopted it.
It was incorporated into international sepsis guidelines. Hospitals allocated massive financial resources to keep it on formulary. It became a perceived standard of care based on a single, heavily scrutinized data set and overwhelming mechanistic plausibility.
But the scientific method eventually demands replication. Years later, independent investigators conducted the Prowess shock trial, a larger, more rigorously controlled Phase 3 study.
And Prowess shock revealed that activated protein C provided absolutely no survival benefit for patients with septic shock.
Worse, it confirmed a severe safety signal, demonstrating that the drug significantly increased the risk of catastrophic, fatal bleeding events.
The biological cure was actively causing harm, leading to the drug being entirely withdrawn from the global market. The parallel to the high-dose vitamin C narrative is just chilling. A compelling biological story, early, small-scale positive data, rapid guideline adoption, massive global enthusiasm, followed by a definitive Phase 3 trial that exposes a lethal paradox of harm.
It proves that mechanistic plausibility can never substitute for empirical evidence of patient-centered benefit.
So where does this leave the future of ascorbic acid research in the ICU? Does the Victory trial mean we completely abandon the investigation of vitamin C in critical illness?
The sources suggest that the research isn't dead, but it requires a fundamental redesign. If we acknowledge the hazards we discussed, the acid load, the pro-oxidant state, the oxalate future trials must proactively engineer solutions to those specific mechanisms. For instance, addressing the formulation acid load.
Right. Researchers are hypothesizing that utilizing neutral pH formulations, such as sodium ascorbate, could potentially mitigate the severe acid-based arrangements seen with raw ascorbic acid infusions.
By buffering the massive dose, you might avoid the iatrogenic vasoplegia and myocardial depression.
However, swapping to sodium ascorbate doesn't necessarily solve the oxalate nephropathy problem because the terminal metabolic breakdown product remains exactly the same, which leads to the second major proposed shift in research: biomarker-guided precision medicine.
Instead of a blanket monolithic approach where every patient meeting a broad clinical criterion receives the exact same massive dose, future trials need to define specific patient phenotypes.
This might involve utilizing rapid bedside assays to measure a specific biomarker of redox stress, or dynamically tracking serum ascorbate levels.
Exactly. And only administering targeted doses to the subpopulation of patients who exhibit a specific, defined biochemical profile. We have to move away from the sledgehammer approach of giving 16 grams to everyone and move toward precision pharmacokinetics.
And finally, future research may simply need to focus on optimizing targeted physiologic dosing, finding the exact threshold where we maximally replete the vitamin without crossing the boundary into toxic pro-oxidant harm.
But the most critical caveat for practicing clinicians is that these concepts, sodium ascorbate, biomarker guidance, targeted dosing thresholds, are currently nothing more than unproven hypotheses. They are strictly the domain of future, rigorously controlled clinical trials.
Which brings us to the immediate practical synthesis for you, the listener. If you are prepping for interdisciplinary rounds in the MICU tomorrow morning, evaluating order sets in the emergency department, or serving on a committee managing resuscitation protocols for your burn center, the mandate from the Victory trial is unambiguous.
Until the precise dose, the optimal formulation, and the exact clinical phenotype are unequivocally defined by new Phase 3 evidence, routine high-dose intravenous vitamin C must be completely eliminated from standard order sets.
Its use should be strictly confined to the boundaries of formal, institutional review board-approved research protocols. The standard of care must definitively shift. Routine utilization must be immediately dialed back to encompass only true deficiency or physiologic repletion indications.
We must internalize the ultimate philosophical lesson of the Victory trial here. Mechanistic theory is fundamentally insufficient. A perfectly mapped biochemical pathway on a whiteboard does not guarantee, and clearly does not predict, survival in an intensive care unit bed.
Patient-centered outcomes measuring what actually happens to the mortality and morbidity of the human being remain the solitary truth in evidence-based medicine. We started this deep dive looking at what we desperately hoped was a cheap, safe biological sealant for the catastrophic capillary leak of severe burns.
And we learned that administering 50 milligrams per kilogram every 6 hours does not stop the leak. It generates an 11% absolute risk increase in death or persistent organ failure, likely driving oxalate crystallization, paradoxical oxidative destruction, and profound acid-base collapse.
The early stoppage by the Data and Safety Monitoring Board was a necessary intervention to protect patients from a therapy that was actively compounding their critical illness. It is a stark reminder of the ethical imperative of continuous, rigorous scientific evaluation.
Mechanism is never enough. Patient-centered outcomes are the only truth.
Which leaves us with a final provocative thought to consider as you head into your next shift. The Victory trial meticulously demonstrated how a simple, everyday nutrient can become highly toxic when pushed to its limits under the guise of pharmaconutrition. But it forces a deeply uncomfortable question about the rest of our practice.
How many other routine, common-sense therapies currently sitting quietly in our standing ICU order sets interventions we utilize every single day based on legacy data and biological theory? How many of them are just biological duct tape, silently waiting for a rigorous Phase 3 trial to expose their harm?
Keep critically analyzing the status quo. Keep questioning the guidelines. Thank you for joining us on this deep dive, and a special thank you for sharing these incredible sources. Until next time.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.
En el JAMA The Victory Trial, high dose vitamina C en el IV, severe burns, una esperanza, pero la curva no avanza. Early termination for futility, yeah, causa más mortality. Doctor, stop, the data is cold, a story the numbers told. More organ dysfunction, mi amor. Placebo tuvo un adjusted RR menor. No victory in the end, no. No victory in the end, no.